Okay, I'm going to start. Thanks everyone for attending for this lecture, and I'm going to talk about single photon emission computed tomography, and which is basically very similar to Anger camera, with the exception of the protocols and some system designs that is different compared to Anger camera. So I'm going to cover mostly the components of the SPECT system, which was touched on during the lecture for Anger camera, and then move on to more advanced applications, which is cardiac SPECT application, and also quality control and quality assurance. So this is what I'm gonna focus on today, and just a flashback. Imaging modalities in hospital setting and medical centers are the four main categories are X-ray and CT, nuclear medicine, ultrasound, and MRI, and these are the main modalities in any medical imaging center. And we have transmission, transmission imaging when it comes to nuclear medicine, and transmission is for X-ray and CT, where the source radiation source is outside the human body, and the detector is the other side of the patient, and we get the images. On the other hand, in emission tomography, emission-based systems, we have the radiotracers injected to the human and the patient, and then the detectors are gonna detect these radiotracers, the gamma rays that is coming from within the human body. And as most likely Moses talked about this a couple of lectures ago, SPECT and gamma camera share most of the components, and as any other imaging system, imaging modalities, we have a detector system, we have a collimator system, computer system, and gantry system. The most important parts for SPECT and gamma camera are detector systems and collimator systems. And within the detector system, we have radiation detector, photodetector if the system is based on scintillation detector, then you have to have a photodetector to convert the scintillation photon signal to electrical signal. And then you have a readout circuitry to process the electronic signal from the photodetector, and then post-processing and preparing for reconstruction. And readout circuitry is, we typically divide it into front-end electronics and back-end electronics. Front-end, we are talking about the amplifiers, preamplifiers, signal shapers, and thresholders, and then the back-end electronics is typically analog to digital converters, and then constant fraction discriminators. These are, in more modern systems, are coming to the front end, and the back end is more on the general acquisition and signal processing, post processing and preparation for image reconstruction. So the conventional Anger camera is based on sodium iodide, a large slab of sodium iodide, thallium dope monolithic crystal, and as you already know, density of sodium iodide is pretty low, 3.7 gram per cubic centimeter, and light output is about 40,000 photons per MeV, and decent decay constant, which is actually not as important compared to PET, and a photoelectric fraction at 140 kiloelectron volt of about 80%. And the conventional Anger camera, even up to this day, the dual head gamma cameras are typically they have between 30 to 50 PMTs, photomultiplier tubes, and typically they have a parallel hole collimator with hexagonal holes or square holes, 2 to 6 millimeter diameter and also length. So how they are operating actually is when you have laser pointer. Let me find the laser pointer here. Okay, when you have a gamma going through collimator hole, impinging upon a scintillator, you have a light diffuser called light guide, and then you have the signal is spread over multiple PMTs. Scintillation photon is going to be collected over multiple PMTs, and then using a center of gravity similar to this, you can estimate the position of the gamma ray interaction, because in this case, in this very example, you get larger signal collected by this PMT compared to this the right PMT, and obviously you can estimate, where the gamma ray was collected. Gamma ray was interacted with the scintillator, and this is in one dimension. The other dimension is the same, exact same, and that's again center of gravity, or more commonly used phrase is angular logic. Center of gravity and angular logic is exactly the same, and that's the conventional gamma camera. So you get the signals, and processed, with the amplifier, and preamplifier, amplifier, and shaper, and then acquired by the DAC, typically digital analog to digital converter, and thresholds, and etc., and then sent to a PC for image reconstruction. And the second most important, the other most important component of the system in gamma camera and SPECT is collimator. The collimator is, in a way, behaving as kind of a front-end component in a SPECT. So the detector resolution is important, quality and how a small, resolution, a good resolution the detector has is important. But the more important component in a SPECT is collimator, because collimator is the dominant factor in, arriving at a complete system resolution. And collimator has the largest impact, basically, on the spatial resolution and also the image as signal to noise ratio. And remembering, from the basics of SPECT or gamma camera versus PET, in a SPECT you have single gamma, coming out of a human body, and that therefore there is no coincidence imaging to be applied here, and therefore you have to have a way of determining the direction along which the gamma ray interacts, is coming from and interacts with the detector. And that's why you have to have a collimator system. And typically the collimator material is some, very heavy, high density material, typically lead or tungsten. Lead is dominant material, and tungsten is more and more being used because of, as you can see, the higher density compared to lead. And I will show you later why it's important, to go with tungsten compared to lead, if price allows, if cost allows. And conventional collimator systems that have been used are parallel hole and pinhole, and we have the converging collimators. These three are actually the most have been used most, and the first two that are the most dominant in the collimators in any that comes with any system, SPECT system or gamma camera, is parallel hole and pinhole. So just as I said, the parallel hole and pinhole collimators are the most important ones. So let's go through the formulation of what the resolution is for parallel hole and pinhole. And the formula is here. This is just for a reference, and I guess you have access to this lecture afterwards. So this is a simple formula for deriving the resolution of a collimator, as well as the sensitivity of a collimator. Because remember, the sensitivity of the system is a factor, is a very important factor, a metric that comes with any SPECT or gamma camera, and that's the in there you have geometric sensitivity and also detector sensitivity, because detector sensitivity is a function of absorption, absorption capability of the detector. So here, let's call it, geometry of the collimator, which is, geometrical sensitivity of the system comes from collimator sensitivity here. And we don't talk about detector sensitivity at the moment, because that's a different formula, but then you can multiply these together. In resolution of the collimator, when you look at, this is the collimator here in parallel hole, and the length of the collimator in pinhole is from here, where the detector sits, up to here, where the pinhole is. And general rule, if you're closer to the collimator hole, your resolution is better. Looking at both formulas, and sensitivity is actually works the other way around. For parallel hole, and the closer that you get, your resolution is better, but the chance of collecting more gamma ray counts is smaller in parallel hole. And again, these are based on these formulations. And we can play with these formulas later, and then plug in a couple of numbers here and there, and see for yourself, how the sensitivity is going to change. So overall, this resolution, and there is always a resolution and sensitivity trade-off in any imaging modality. And in this case, let's focus again on parallel hole collimator. As you can see from the top, in the top left figure, if your source, if the collimator length is short, you'll have a higher chance of collecting gamma rays coming from the source, from within the human body, and your sensitivity again is gonna be higher, but resolution, you can see that you are collecting more gamma ray photons, and hence you can't exactly determine where the directionality of the gamma rays, where exactly they are coming from. Is it from within the same object inside the human body? And if you increase the collimator length, obviously your resolution is going to improve, because you're just allowing a smaller number of gamma rays to go through the collimator hole and interact with the radiation detector, and obviously getting the signal out and process it. And obviously you will have smaller system sensitivity, because you are collecting a smaller number of photons. Again, this is another way of representing the the trade-off between resolution and sensitivity. I'm focusing, maybe I'm focusing too much on this, but this is what you will hear more and more when you listen to talks and lectures at the conferences, because there is always a resolution and sensitivity trade-off, and typically it's very hard to achieve both at the same time. without increasing the system cost by a large factor. So if you have a short collimator hole, again, your resolution is going to be worse, but sensitivity is going to be larger, and vice versa. And then there is another factor that I didn't talk in the previous slides, and I'm focusing here on it. It's a septal thickness, and consider that this is the collimator holes, and this is the collimator material, lead or tungsten. Okay, there is obviously, if you have a thickness of the material, absorbing material, lead or tungsten, if T is larger, okay, then you are having a higher chance of absorbing the oblique gamma rays, and that means your resolution is going to be better. Obviously, if you have a very thin collimator wall, if T is so small, then you will have a lot of artifacts, and gamma rays are going to pass through these walls without much problem, and that means your resolution is going to be jeopardized. So as a rule of thumb, the formula presented here is actually based on 5% transmission, meaning only about 5% of the gamma rays are allowed to be passing, going through the collimator wall and interact with the detector material. And mu is the linear attenuation coefficient of the collimator material, and W is the minimum path length for the gamma ray to be stopped for hole length L, and the diameter D, and septal thickness of T. Obviously, longer hole length means that T can be slightly relaxed. If you want to put it into perspective, you want to have a small T. Main reason is material. Material means cost and complexity. Of course, you can't make the collimator wall too long, because you're basically reducing the sensitivity, system sensitivity. Even though you're improving the resolution, you're reducing the sensitivity. So there is always a trade-off here. That what is the most important factor to take into account here. And again, if you can relax on length of collimator wall, that means longer collimator wall, that means T can be smaller, and meaning lower cost, typically lower cost. So there is obviously a penalty that you have to pay when it comes to septal penetration. If the septal thickness is not large enough, then you will have all sorts of effects here, and we call it septal penetration and septal effect. If you have the total response function of the collimator as TRF, and then you have a geometrical response function, and then a septal penetration response function and a scatter response function. These are all components together to make the total response function. So if you have a high energy, HEAP means high energy all-purpose collimator. MEAP means medium energy all-purpose collimator. So for high energy collimators, these are designed for much higher gamma ray energies, okay, for different applications. And obviously, if you have the same collimator wall length that you use for 140 kilo electron volt gamma rays, technetium-based isotopes, then you will have a lot of penetration through the septal thickness, and the gamma rays can easily interact, pass through and interact with the detector, and then you will get these artifacts. And if you use the same, for this type of energy, large, high energy gamma rays, if you use MEAP collimator, there is no way that you can get away, remove the septal penetration effect. And again, these are all of these have to come together based on the end application that you have in mind, the protocol, what type of imaging study needs to be done. Typically, when a medical center or hospital purchases a gamma camera or a SPECT system, they just don't come with parallel hole collimator. You have all sorts of collimators with different properties. They come with MEAP or high energy all-purpose, and pinhole, typically with 5 or 6 different type of collimators comes with the system, depending on the application again. And the most important factor to take into account is the gamma ray energy that is going to be used in that very specific imaging application. So if you have, in this slide shows the resolution versus distance, depth of the radiation source or radioisotope location within the human body, and what is going to be its effect on resolution. So D is the collimator diameter. Okay, we have, in this case, we have 1 or 2 millimeter, and hole length. Okay. 3 centimeter, 2 centimeter, and 1 centimeter, and the point source depth within the patient. And we are talking about 10, 15, 20, 25, 30, and 35 centimeters. So 10, 15, 20, 25, 30, 35 centimeter, okay, within the body. Obviously, even, as I said before, you want to get the patient as close as possible to the collimator and the detector to get the best resolution. And here we have the proof. If you have, if the source is 10 centimeter deep within the patient, with a very good collimator resolution, because the collimator hole is only 1 millimeter diameter, you get very nice reconstructed image. And you don't have much blurring here. But on the other hand, with the same collimator, okay, and the same collimator diameter and hole length, at 35 centimeter deep in the body, you get worse, a much blurred reconstructed image of a point source. And it's going to show on the line profile and the profile that you draw through the radiation source, the isotope location within the patient. So again, these are all compromises that you have to take them into account. What type of collimator you should be using, and depending on the patient size, and also the energy of the gamma ray, depending on the imaging protocol. So just a fun fact about these collimators, these are typically very heavy piece of materials, right? And then if you look closer, for example, here you see one of the holes is kind of squeezed. Why? Because during the perhaps during the manufacturing process, or simply put, you can actually drop the collimator, and then a bunch of holes are gonna combined or be damaged, and then you will see the effect on the image. I'll show later what type of image you get. Actually, it's important that the collimator is important in the uniformity test and quality control of the gamma camera and SPECT systems. And these are going to show up in the image. So rule of thumb, typically in the conventional gamma cameras, 200 gamma cameras, we are getting about, we are just collecting about 1 out of 10,000 emitted gamma rays. Okay, if you have 10,000 gamma rays coming from the patient, then there is only about one of them that is being detected, okay, by the dual head gamma camera, and that's about 2 orders of magnitude, okay, different compared to what PET can do. PET has much higher sensitivity because there is no collimator. There is no physical collimator. They have coincidence collimation, but no physical collimation. And again, the collimator, it depends on what type of material you're being using and what type of energy. And typically, it's a function of the energy, it's a function of the distance and the collimator physical properties. So overall concept of tomography acquisition. I don't know if Moses has talked about this or not, but if you have assume that you have a single head gamma camera or a single head SPECT, then this is your patient. You rotate the detector head, which is detector and the collimator, around the patient. And basically you're getting planar images, and then you're gonna superimpose them in a space called sinogram, and then prepare them for image reconstruction. So this is a sinogram, and as you can see, for example, in this case, you have the first line of the sinogram as in this projection, and when you're rotating the detector head around the patient, you are filling up another line in the sinogram, which is basically a function of distance as well as the angle, right? And obviously, if you want to have a complete, sinogram, you have to have more, larger number of these angles, angular sampling, which I'm gonna talk about later in the next few slides. So steps for what we do for filter back projection. We acquire the projection images, the planar images, then compute the 1D Fourier transform of each profile, basically we are converting them to a spatial frequency domain, and then apply the filter in the frequency domain, compute the inverse Fourier transform to convert back to spatial domain. Because the conversion here is much easier. Applying the filter is much easier in this domain compared to the spatial domain, and then perform the back projection. So basically, you have one projection, two projection here, and 4, and then if you have much larger number of sampling, you can actually represent the almost true image of the object of interest. And there are different types of filters. You have the most straightforward one is a RAM filter, and then you have Shep-Logan and Hanning filter, and each one of them has its own properties and its own effect on the final image. Again, filter back projection is one of the technique, one of the methods to reconstruct the image. And still to this day, FBP is the most prevalent, reconstruction method, because this is the fastest. It's not gonna give you the best resolution possible, but it's gonna be the fastest method compared to the iterative reconstruction. So these are basically the steps. Again, the projection acquiring, and then back projection, and then the filter. This is the filter back projection compared to just a simple back projection method. And I think Moses already talked about these. I'm going to show here the initial image, the effect of different filtering here. The initial image, and if you don't have a filtering, you see the widening here. If you apply the RAM filter, you get a little bit noisier, depending on voxel size. You get kind of a noisy representation of the image. And then when you're applying for example, a Hanning filter, you get slightly better compared to no filtering, right? So for gamma camera and a SPECT, SPECT imaging, there are multiple things that you have to think about when you're acquiring, projection. I showed you before in the sinogram space that you want to have a full sinogram, right? That means your angular coverage should be good enough, and your angular sampling also should be good enough. These are two different terminologies. I'm going to show you here, what they mean and how we can go about them. So this is again, something that it's freely available in MATLAB. It's a radon and iRadon. Radon for projection and iRadon for FBP. You can easily do the reconstruction, image reconstruction, and see what angular coverage and the angular sampling means in practice on these images. So from top left, this is FBP 45 degrees of coverage, angular coverage, meaning the detector was moved from one location and covered only 45 degrees around the patient instead of 360 or 180. Okay, so typically what you want to have is 180 degrees. Okay, slightly more than 180 degrees of angular coverage to reconstruct the image without much artifact. So this is only, top left is only 45 degrees. And then here is 90 degree, and the degree step angular sampling is 1 degree in all images. And then you have 135 and then 180 degrees. So this is the final this is the very close to the true image that was used, to do the projection and back projection. So obviously you want to have large angular coverage. Okay. So number of projections or angular sampling. This is another, another important factor when you're acquiring data, and they are intertwined, and you can't say one is enough or one is more important compared to the other. Both of them are important, equally important. If I want to prioritize, you have to have a large, angular coverage. Okay, and then go about angular sampling. If you don't have good angular coverage, then it doesn't matter if your angular sampling is 1 degree or 0.1 degree or 10 degrees. You're not gonna get a meaningful image out of your system. So this is again true image, and from top left is we are talking about 180 degrees coverage. So in the previous slide, we showed that we need 180 degree coverage. So assuming that that's given 180 degree coverage, this is one projection, 2, 3, all the way to 360. So when you get about 180 steps, 90 steps, meaning every 2 degrees, you are getting very good, actually very, very good image, compared to the true image. This is again FBP. It's not iterative reconstruction, it's FBP. If you want to relax the angular sampling between and go from 2 degrees to 5 degrees, you see all sorts of artifacts, right? So, in iterative reconstruction, most of these is going to be, taken care of. But, as I said, FBP is the main reconstruction method that is being used and provided by all the manufacturers. So we saw both, angular sampling and angular coverage, and typically, a couple of degrees is some what is needed. And again, if you want to provide a very quick image of the patient, maybe you can relax on the angular sampling, but not angular coverage. So partial volume effect. So what is partial volume effect? In the most, the simplest way that I can describe this is if your system resolution, if your system is capable of, resolving, let's say, 6 millimeter features within the image, okay, then your object, the object that you're interested to see the activity in, it has to be about twice the size of the FWDHM resolution of your system. And of course, this is a function of multiple factors are important here. Scintillation crystal size, detection efficiency, geometrical arrangement, collimator type. There are many factors that can influence the partial volume effect. And this is another way of representing what partial volume effect is. And from left to right, these are cylinders with 48 millimeter all the way to 6 millimeter. And again, the system resolution is about 12 millimeter here. Okay, and when you get about 24 millimeter, because it has to be the smallest feature size that you want to resolve without paying a penalty in the reconstructed image, has to be 2 times of the system resolution, right? So we are talking about a system resolution of 12. And if you look at the 12 millimeter diameter cylinder, you're not actually, getting the true line and the true line profile of that, cylinder size. And when you get to 24 millimeter, that's obviously changes, and you start to actually preserving the information that you are interested in. And recovery coefficient also is, again, something intertwined with partial volume effect. A recovery coefficient of 1 can be obtained when the size of the object is, again, two times of the FWDHM resolution of the system. And note that the recovery coefficient also depends on the radionuclide concentration in the object and the surrounding tissue. So, for example, if a cylinder contain no radionuclide and we're placed in a background, for example, containing a uniform level of radionuclide, the recovery coefficient would be reciprocal of those shown here in this figure. We can move on from this. There are different strategies to correct for partial volume. Again, the most important one is to have a better system, a better detector, better collimator, so that your resolution, system resolution, is better than, so that you don't have problem with resolving small features within the image. So there are mainly 2 strategies, correction strategies. One of them is reconstruction-based correction, and the other one post-reconstruction correction. And for the former, we are basically talking about iterative reconstruction methods, such as a maximum likelihood expectation maximization, which I guess another colleague of mine is going to talk about this in the later lectures. So in this case, you incorporate the system PSF information to compensate for non-stationary resolution. Basically, what you're doing, priori information can be used from co-registered anatomical information, and those information typically come from MRI or a CT. And for post-reconstruction correction, typically what you do is that the pixel-guided approach use binary maps from CT to redistribute the reconstructed activity in the regions of interest. So basically, you are trying to compensate for what you have lost in due to the partial volume correction here. And model-based approaches simultaneously recover the size and the activity concentration of small regions of interest, small features in the image, improving estimation of lesion activity when the object size is not necessarily unknown. And another factor that is important for a SPECT and gamma camera is attenuation effect. Typically, what we apply for attenuation due to water, we typically say a human body is mainly made of water, is 0.15 per centimeter for 140 kilo electron volt photons. And obviously, when you have higher gamma ray energy, then this number has to be changed accordingly. And reconstructions of this should be uniform. If you correct for the attenuation effects, then the reconstruction of the disc should be very uniform. And typically, if you don't do this, the attenuation causes a distortion that increases with the object size. And typically, if you have a patient, which is a small patient compared to a large patient, the attenuation effect is going to be different. If you have a patient with body mass index of above 30, your attenuation correction is a must compared to much smaller patient or much smaller object to be imaged. So this is just an example of technetium-based myocardial perfusion image, and also the breast attenuation here on the top. So for SPECT system design, you have to think about what the end application is. You have multi-purpose SPECT. Remember, the conventional gamma cameras are actually multi-purpose SPECT because you can actually tune them for different imaging applications. They're not excellent systems, but they can be used for different applications. They're not organ-specific imagers. So you can apply them for cardiac imaging. You can apply them for you can use the protocol for bone imaging and brain imaging. So yeah, again, they are not excellent systems. Dual-head gamma cameras, conventional dual-head gamma cameras, they are not excellent systems in terms of performance, but easy and flexible and relatively cheap compared to very high-end systems, and then can be repurposed, used for different applications. So when you're thinking about the SPECT system designs, you have to think about what type of patient configuration we are talking about, and the data sampling, and do we want a system with transmission photon source for attenuation correction, or just combine it with a CT. And you have to think about multiple parameters, and at the end of the day, it goes back to what is needed for your imaging for medical center, for your nuclear medicine division. What do they want to use the SPECT system for? So I'm going to focus here on cardiac SPECT, and the reason for focusing on cardiac SPECT is because of the coronary artery disease, or CAD, still number one cause of death. And still to this day, cardiac SPECT accounts for about 50% of the cardiac imaging in the United States, and very similar trend in the rest of the world. And myocardial perfusion imaging, MPI, is most common non-invasive imaging for CAD patients. So remember what I said before, dual head gamma camera stands, DHGC. We are talking about collecting or detecting 1 out of 10,000 gamma rays coming from the patient, right? So system sensitivity is about 0.01%. And mainly the physical collimation to blame. And another reason for this poor sensitivity when it comes to cardiac imaging is about 2 to 3% of the tracer goes to myocardium. And believe it or not, the dual head gamma cameras, they are not optimized for cardiac imaging. These are all-purpose gamma cameras, but you can use them for cardiac imaging. Obviously, if you have a better system that with better coverage, detector coverage, that is covering the patient front thorax, then you're gonna get better sensitivity and resolution. And new tracers, with new tracers, there is a need for better contrast for restless stress imaging, and compared to technetium-based isotopes. And with new tracers, there is a need. Some of these new tracers, they have actually a better uptake in the heart and higher extraction at higher blood flow. And because of these reasons, because of this past history of gamma camera and poor sensitivity and poor performance when it comes to cardiac SPECT, there has been a huge race, to build better systems for cardiac dedicated systems. And this race has been, going on still, and started about year 2000. And the reason for that is there is a huge market and lack of high performance systems. So with the dual head gamma camera, what you do, again, you just rotate the dual head gamma camera around the patient and then acquire images. They're fine, they seem to be fine. But remember, the myocardium wall is about like 1 centimeter thick. And if you want to, get information about partial infarction, then your system resolution has to be better. And obviously your system sensitivity has to be better. And these conventional dual head gamma cameras are not up to the task. So typically with the dual head gamma camera, MPI imaging is about 15 to 20 minutes, and low energy, high resolution collimator with diameter of 1.5 millimeters, a septal thickness of 0.2, and whole length of 35 millimeters is being used. And again, not optimized for imaging a heart, low sensitivity, very low sensitivity, but cost is very decent. And anywhere that you go in this country, at least, to any medical center that you go, there is a gamma camera sitting there. So it's widely available. So to put into context, the cost of a, purchasing cost of a gamma camera, dual head gamma camera, is about $250,000. When a hospital wants to buy it, it's about $250,000. So there are other systems coming to the already in the market, okay, commercially available. I want to focus on them in the next few slides. The most famous one is the top two, GE Discovery 530 and DSPECT from Spectrum Dynamics. These two use CZT, which is a semiconductor detector. Instead of the conventional conventional scintillator-based detectors, they use CZT. And the design of both of them are body contouring, different, same pixel size. These two systems actually use the same detector from the same manufacturer. And the first one from GE is multi-pinhole geometry in 3 rows and the whole diameter of 4.75 millimeter. The other one, the SPECT, is parallel hole, use the parallel hole, but with a very smart design. And these two systems, again, because of the material that they use for the radiation detector, collimator is the same material for the radiation detector. It costs about 3 times more than the conventional dual head gamma camera, about $750K. And Siemens IQ system and Digirad cardiac system, I'm gonna dedicate one slide to each one of them. So remember from a few lectures ago, maybe Lisa talked about this, or Moses talked about this 2 lectures ago, that direct conversion, which is easier to handle the radiation signal, the radiation detector signal, when we have semiconductor detector. It's easier. There is no intermediate layer of the photodetector. At the end of the day, you have a cost issue. Even though semiconductors are more favorable, you have cost issue. Because of the CZT, it outperforms almost everyone else, right? In terms of resolution, energy resolution, but not cost. And you have to have a very thick crystal, thick CZT crystal to stop the gamma rays. So the conventional scintillators, you know, using this slide from before, the conventional scintillators are sodium iodide and cesium iodide for SPECT, the first 2 lines, and the last 2 lines are for PET. So these are very easy to get. You can grow these crystals in large volume, single crystal in large volume, and price is very decent compared to CZT. To put it into perspective, the best price for a CZT detector is about $100-something, the best price, $100-something per cc. But for sodium iodide and cesium iodide, we are looking at between $5 to $10 per cc. So it's an order of magnitude difference. That's why the price of these systems like GE Discovery is 3 times more than the conventional dual head gamma camera. So this is the GE system, and this is patient. As I said, you know, they are covering, the detector coverage is more on the front thorax, right? And they provide excellent resolution. Sensitivity is decent. And if you look at the design, it's a stationary design. It doesn't need to move. It's not like dual head gamma camera that moves. The detector head moves around the patient. So that's one of the beauties of this system. That is a stationary, and then there is a higher chance of being able to image the patient dynamically. The spectrum dynamic, on the outside, it's called D-spec from the spectrum dynamics. On the outside, actually, it's stationary. So the GaN3 doesn't move around the patient. But what moves is these detectors. They are sweeping, because these are parallel hole collimators. They're sweeping across the patient now to get angular sampling, more angular sampling. Okay, and so because it's parallel hole, right? You know, it's not like pinhole that you can see the entire field of view. It's just seeing the portion of the field of view, and that's why they have to. For example, this detector has to swipe from this angle all the way to this side to see the entire field of view. So there is a component within the GaN3, not the GaN3 itself, that is rotating. Because of the high price, they ended up, you know, having 2 versions of the system with 6 or 9 detector columns. Each of these are called detector columns, but they provide the best, perhaps the best resolution available today in commercial systems. And Siemens IQ SPECT is the same as dual head gamma camera, but with using a converging collimator. They call it cardio focus, just to focus on the heart region to provide the better images. You see, that's same sodium iodide slab, and collimator is, you know, this part is really converging and zooming in into the heart region. There is a Digirad Cardius system, which is based on cesium iodide and avalanche photodetector. They provide a very good resolution, decent resolution, and but from the footprint point of view, they are the smallest system available in the market. So now, remember a few slides ago at the beginning, I was talking about detector is not very important. Okay, detector resolution is not extremely important compared to the collimator resolution. So here is a slide that shows that actually detector resolution can be important. So consider that this is the conventional, if you consider and assume that this is a detector, conventional detector, large, and this is the patient. If you have a pinhole collimator, imagine that you can make this detector smaller and smaller and smaller and bring it closer to the patient, and then you can actually have a lot more detector heads around the patient. So this way you can actually have both sensitivity and resolution improved at the same time. But that means you have to have a better detector with higher intrinsic detector resolution, right? So that means you have to have technology that can actually make things smaller and at low cost. So that's what actually at MGH is going on, and we have been doing this using laser processed detectors to improve the intrinsic detector resolution at low cost, because the process is completely automated. Detector fabrication is automated, and with very precise laser processing, so you can actually have detectors ready in a much faster time. That means lower cost, and you can apply to conventional crystals, which are cheap. So that was the goal of this project. It's not in the market; it's an ongoing project. And in comparison, the cardiac SPECT system at MGH, the effort that is going on at MGH. So different designs, obviously, based on different number of detector modules, compared to the main systems. The GE 530, the dynamic spectrum, and the dual head gamma camera. You see, the orange one is system sensitivity, and this is resolution. So remember that resolution of the newer systems are actually improved by resolution recovery. So it's kind of you're applying a resolution recovery point of spread function modeling in your reconstruction, but you're increasing your noise, signal to noise ratio. In a way, if you want to measure the true intrinsic resolution of the system, for DSPECT is about 20 millimeter. The conventional dual head gamma camera is 15 millimeter. And GE system, the new GE system, CZT-based system, is 15 millimeter. With the resolution recovery, you get 8 millimeter here and 6.7 millimeter for GE system. And in the designs at MGH cardiac system, you can actually get both of them. These numbers are without resolution recovery. So you can actually, in a way, get at the same resolution as conventional dual head camera, you can get about 17 times more system sensitivity. So these are encouraging results that may lead to better systems at more affordable costs for medical centers. So it's a comparison to MGH system compared to GE with very high resolution mode or low resolution mode, high sensitivity mode. So you can see that we start getting to resolve 3 millimeter or 4 millimeter pixels. Isotopes, radioisotope cylinders, right? And that is close to what PET can do today. The conventional PET can resolve 4 mm rods. Okay, conventional SPECT can do about 10 mm to 15 mm rods, not 4 mm. So if everything goes well within the next few years, then there is a chance that then there will be a new system that can provide both resolution and high sensitivity. Okay, so we're going to touch on quality control for SPECT and gamma camera. When I say SPECT here, you can include gamma camera, and because they are the same. For a SPECT QC procedure, we are talking about multiple tests that has to be done either daily or every 3 months, or weekly, depending on the manufacturer and depending on the state. It also depends on which state you're at and the regulations, basically. And if you have a CT system, if you have a transmission CT, if you have a transmission source that you get your attenuation map from, okay, you have to do the QC procedure on that system too. Or if you have a completely standalone CT, you have to do the QC procedure on that component as well. And obviously you have to, at the end of the day, for SPECT and CT, if you have both components, they have to be co-registered and do the procedure, the QC procedure on both as a single system. So as I said, the SPECT QC procedure, some of them are mandatory and some of them are daily, and the frequency of these may vary among the different states here in this country. And of course, it has to be consistent with the radiation license. So for example, the energy peaking, which I'm gonna talk about later, next slide, is mandatory and it has to be done daily. And a uniformity test also is mandatory and has to be daily. Upon receiving the system for major upgrades, there is a NEMA standard acceptance test for using the NEMA standard. Has to be done. In most hospitals, you have to actually perform that NEMA standard to actually right after major upgrades. If you have like a detector component to be replaced or photomultiplier tube module that has to be replaced, you have to do those. So for energy peaking, the purpose is to make sure the camera is counting the gamma rays, the correct gamma rays and gamma ray energies. Because remember, you have a patient. Depending on the patient size, you will have a lot of scatters. Okay, and if your photo peak location is shifted at lower or higher, typically lower, then those useful gamma rays are not going to be counted. So you have to, the energy peaking is a mandatory test that has to be done daily to count the correct gamma rays with the correct energy. And typically what is being done is a point or sheet source is used to illuminate the entire useful field of view. And what then you have to use a pulse height analyzer, and typically what is being used is about 10% right side, 10% left side, overall 20% above around the photo peak location. That's the energy window, and within this range, you have to statistically acquire relevant number of gamma ray events, and then apply care fitting, make sure that your photo peak and energy spectra doesn't look weird. There are cases that you will see double peaks or much broadened photo peak, and that means that, you know, for example, one of the modules or a couple of detector modules are not performing well, or you know, the photomultiplier tube is out of tune for any reason, or there is a crystal that is almost decoupled from a photomultiplier tube, and that means not enough number of optical photons are being collected. That means your photo peak is shifted. So if you have a bad energy spectra, that's shouting for proper calibration. Another test is uniformity test, and the purpose is to verify if the camera's sensitivity response is uniform across the detector face. And again, typically point or sheet source used, and you know, everyone prefers to use technetium, but sometimes it's not available, and they use cobalt source, whether it has a double peak, a double photo peak, but it's close enough. And depending on the manufacturer recommendation, you know, this procedure, uniformity test, can be done with or without collimator. Without collimator is called intrinsic, with collimator is extrinsic. And but typically, because we are talking about the response of the detector here mainly, intrinsic is more relevant because no collimator grid pattern. Remember those squished, you know, collimator holes that I showed you before? Those are out of the picture. So you're basically testing the true function, response function, and uniformity of your detector. And a uniformity test is performed typically right after the peaking test, because these are very relevant. And you know, with the conventional dual gamma camera, you have you generated 256 images. Image of single image of 256 by 256 voxels with 3 to 5 million counts to make it statistically relevant, so that your noise is not going to be dominant. And per NEMA standard, 10,000 counts for the center pixel of the flat image has to be acquired so that you can stop the acquisition. And what you do also is you do the integral uniformity and differential uniformity. I'm going to show you in this image that, you know, what they mean. So remember, you know, the intrinsic resolution that I said, that's important to do intrinsic rather than extrinsic. So this is a crushed lead septa. You know, one collimator or a group of collimator holes were crushed together. So then you don't get counts. You know, you don't get gamma ray counts. And if a non-uniformity, this non-uniformity is from the energy window, which is which is shifted. That means the photo peak was shifted, and you're not collecting relevant gamma ray counts. So when you get a uniformity image, assume that you have like 2 locations. You pick 2 locations. If this is the entire FOV, okay. So differential means in one location, okay, in one location, within 5 pixels, image pixels, the value, the count value should be, as a standard, should be smaller than 5%, preferred less than 3%. When we are talking about integral, 2 locations here, the value, the count value of image pixel here should be within 5% compared to this one, right across the FOV. So that's the integral uniformity. And then you have the resolution and linearity test. The purpose again is to document all these and, for the major upgrades later throughout the year. or preventive maintenance, to perform the preventive maintenance, and then see the documentation when the manufacturer comes over to your center to go through the documentation. These are the images that they want to also see. To document the camera's spatial resolution and its change over time. So, and also to verify if the camera is capable of measuring the straight lines. And typically in this case, you want to have an extrinsic test, not intrinsic, because you're looking at the system as a whole, not just the detector plus the collimator. And what has been used is typically the bar phantoms. You have 4 quad bar pattern in different directions. The lines are in different directions, or just parallel line in one direction or the other direction, or all sorts of patterns. You know, over the years, many different phantoms has been you know, designed and built to measure the resolution and linearity of the system. And there is a sensitivity test, and the purpose again is to document the camera sensitivity and change, and its change over time. And it's not a very extremely important you know, test compared to resolution and, you know, peak energy peaking, but that's something that, you know, in medical centers they do, you know, this type of test every now and then, and that's very useful when the manufacturer, you know, representatives come over to, you know, change or upgrade the system. And counts per minute per megabecquerel is measured, and you have to use a radiation source, calibrated, very well calibrated radiation source to measure the absolute sensitivity of the system. And obviously, geometrical location of the source is very important. That's why they have typically what they have is they put the source with a design and source holder and they place it exactly in the same location with respect to the detector every time, over and over. Then there is a center of rotation procedure that has to be done. This is more relevant for the dual gamma camera, because in the stationary designs, the cardiac specs that I showed you, they're not moving, so the center of rotation doesn't mean anything there. So obviously, when you have a moving part, then the moving part can go out of tune and can cause significant artifacts. The alignment between the mechanical center of rotation is what we want to know with respect to the electronic matrix used for the image reconstruction. And if the error between the image center and the mechanical center of rotation is large enough, then you're going to have a donut-shaped artifact in your image, and your image resolution is not going to be as good anymore. So here is an example: 0 millimeter error, 3 millimeter error, and 9 millimeter error. And obviously, the quality of the larger error is worse. You know, the image resolution is worse than here. This is maybe it's not a very very good image to show, but it clearly demonstrates the effect of center of rotation, error due to the center of rotation. And we have you know, different protocols. You know, when you're designing a study, you have to think of isotope and the dose and the delay time between the injection and acquisition type. And also it's a 1 day or 2 day, depending on the isotope, positioning, energy windows. Energy windows, it's relevant because, you know, sometimes you have a higher energy or a different isotope with different energy, and that and the energy windows has to be properly defined when you're doing the acquisition and of course the reconstruction. The collimator type, the angular sampling, number of projections, image matrix and the voxel size, acquisition time, and if there is a gating, for example, for the cardiac imaging, there is a need for gating if you want to capture, have a very good resolution. You have to capture the heart movement. So this is just an example of imaging protocol for technetium labeled agent, for a comparison between 1-day versus 2-day protocol. 1 day, obviously, it's easier to implement in a way because your hospital utilization is less, and imaging time, within the same day, when your patient comes over, you can scan the patient for rest and stress in the same day, and less complication. So it, again, depends on the isotope, and the 2-day protocol are typically favored because of the pharmacokinetics and acquisition, processing, and the display parameters, flexibility of scheduling for stress and rest. Higher dose can be tolerated, and better gated rest stress imaging. These are all components that comes with 2-day protocol versus 1-day protocol. But what is not favorable is in 2-day inconvenience for the patients. Not every patient is living in the same city or town as the medical center, right? And there is an inconvenience factor that we have to take into account. The delay in the diagnosis. If there is a 2-day imaging, if there is something critical in the first day of stress testing, then you don't want to wait until the second day, okay, or third day. So typically, if there's a very critical thing that you find in the image, you don't want to have the imaging protocol over 2 days, stretch over 2 days. And the fact that you need 2 days of imaging, again, for hospital utilization and camera time block, these are not very favored. Just an example here. There are different protocols. Obviously, this is not a very generalized to all imaging applications, but this is just one example. If there is a 2-day protocol, in day 1 you do a stress dose, and then 10 to 20 minutes later, and get it done. You start the acquisition and get the acquisition done. And the second day, inject the dose, wait 30 to 60 minutes, and then start acquisition. Right? And then if you have a single day, and then you can start with the rest, wait longer for the radiotracer to go through the body, and patient is ready for imaging for the rest state. And then after that, later on, you inject another dose. Of course, it can't be larger dose. It can't be too much dose. And then you start the acquisition again to finish the scan of the patient within the same day. So as I mentioned before, if you're doing a single day acquisition, it needs to, you can't inject the patient with much dose. So this was just an example. So thank you for your attention. And if you have any question, you can shoot me an email or reach out to me. You can come by, visit the lab, or make a phone call, or email me is the best. Thank you. Any questions?